Good morning, America. Good afternoon, Europe, Africa, and good evening, Asia and Australasia. Welcome back to the ISRT Facebook Live. And today we have a very special program in celebrating the World Patient Safety Day. And this project is in collaboration among the International Society of Radiographers and Radiological Technologists, ISRT, the International Society of Radiology, ISR, and the World Health Organization, WHO. And the topic for this year's webinar is WHO Global Patient Safety Challenge, Medication Without Harm. Before we start with the program, I would like to invite ISRT President Donna Newman to give the opening speech.
Good morning, good evening, and good afternoon, all of my fellow professionals around the world. And I thank you for joining us. I am so excited today to be collaborating for the first time with the ISR Quality and Safety Alliance on this webinar. And I thank Dr. Fresh for co-hosting this program with us. I also want to thank Adriana from the WHO for allowing us to continue on our endeavors to have webinars on World Patient Safety Day. You guys are great team members and global stakeholder, and I appreciate you. Now, we know in our daily job, our imaging team is the radiologists, the radiographers and radiologic technologists, and the medical physicists, and we play essential roles in patient safety, not only in radiation safety, but in all other aspects of safety. And today I'm excited to hear from some of our key experts from around the world talk about different best practices. I'm looking forward to hearing about contrast safety and MR and CT, prescribing medicine safety, pediatric safety, and radiopharmaceutical safety. I can't wait to hear what you all have to say, and thank you for joining us.
Thank you, Donna, for your welcome speech. And the next very important is the representative from the WHO, Adriana Velasquez-Perum, and she is the group lead medical devices and in vitro diagnostic for the World Health Organization. Adriana, please have your welcome speech.
Yes, thank you very much. A good day to everyone, everywhere in the world. We're very pleased to welcome you to this seminar organized by ISRT and also with the participation of ISR, two of the very important NGOs in official relations with WHO to support this work. So we welcome and we hope that this information that you will receive today improves patient safety wherever you are. Thank you very much.
Thank you, Adriana. And another very important person, and especially this year, we have a good collaboration with the International Society of Radiology, Quality and Safety Alliance. And we have the co-chair of the ISRQSA here, Professor Donald Flush. Dr. Flush, please have your speech.
Well, thank you and welcome everyone. This is going to be an excellent session that I'm looking forward to learning a lot from. As you all know, imaging is so critically important in the care of patients, whether they're adults or children. And often we look more at the obtaining the pictures and what we say about these, and we look at the actual process of doing what we do. And some of the materials, the agents we use, like radiation, are really silent, but they come really front and center when we have to address the welfare of the patients that we take care of. And so I'm really looking forward to hearing what individuals have to say. And I would like to call out the radiographers and the technologists, especially in the performance of imaging care, because you all are front and center. You're the face of what we do, and it'll be very important for you to understand from the various speakers today aspects of patient safety related to imaging. So thank you.
Thank you, Dr. Fresh. And I now would like to start with our program. We have numbers of panelists, experts here to share their experience about topics related to this year topic of the Global Safety Challenge, Medication Without Harm. Let's start with Adriana Velasquez-Perum, and she is the group lead medical devices and in vitro diagnostic from WHO. And the topic is Medication Without Harm and Imaging, a WHO perspective. Adriana, the floor is yours.
Okay.
All right.
Thank you very much. Well, as you can see today, I'm wearing orange. Orange is the patient safety day today. So you will see that many monuments around the world will be painted orange. So please see that. And I'm very glad to be here with you today. So I'll talk to you something about Global Patient Safety Challenge, specifically dealing with imaging. So as you all know, well-being of patients, following what Dr. Frisch was just saying, it is the goal for all of us. And then we have to say our tools that are the health technologies are tools to support it. They have to be safe, first of all. They have to be of good quality, easy to use, easy to maintain, adaptable, affordable, available, accessible, acceptable. For this, we call the 5 A's. But the first one is it has devices. WHO also has these guidance documents on the above mentioned topics, but we're also monitoring countries in the global atlas of medical devices. What is happening? Do countries have policies for national policies? Do you have health technology assessment? Do they have training for safe use, etc.? So all of this is presented in the global atlas of medical devices. The version 2022 will come out, we hope, in the next 2 months. And of course, we will let ISRRT and ISR and for your members to distribute this important document. Also, WHO is very aware and worried about innovative technologies that could be used in low resource settings. Some of them do involve imaging equipment, and we have to be sure that they are safe and good quality, exactly with the same indicators that we said at the very first slide. Being that imaging is one of the types of medical devices, WHO has a website on medical devices, and here you can find all the information related to all types of medical devices. And then because imaging is so important, there is a specific topic that says strengthening medical imaging. And we would really like to get your support from ISR, ISRT, and many of you to support this work. And we're doing also with radiation safety and with other colleagues. But it is important that you know that this work is ongoing. In this page, we have the non-state actors that are supporting this work. And then here you can see ISRT and ISR. So if you click here in the website, in the WHO website, then you will go to the program, the challenges, and the work plan that we have with these NGOs. So I just wanted you to know that the work that we're doing with these NGOs is actually very important and is monitored by the World Health Assembly and the Executive Board. In the last World Health Assembly, there was a big discussion on the naming and the nomenclature used for medical devices. What we cannot name, we cannot count, we cannot maintain, we cannot do safety. So there is an indication from all member states to tell us that we have to add medical devices, including terms, codes, and definitions in the web-based database and clearinghouse that is called Medebis, and to link this with other platforms so that international classification of diseases. And we have to submit a report in 2023 and 2025. You might think that this is very far from you, but no, it is very close. This is one example. In Medebis, what we have, and I just took one example, we have here the CRM, and then we said, what are the conditions that this is used, the delivery platforms, the related codes, and all the books, the priority medical devices or technical specifications or any WHO resources that call upon this device. So what we would like to ask from all of you is that medical devices have to be safe, both for the healthcare worker and to the patient. And WHO welcomes the initiative from ISRT and ISR to support Medebis so that information is available for users. And we are sure that training and best practices, which we would really like to work with you, are essential to keep patient safety. So let's work all together towards patient safety. Thank you very much.
Thank you very much, Adriana, for a very comprehensive talk that represents the work from the WHO. And we will get back to you during the Q&A session. And for now, I will introduce our next 5 speakers together. We will broadcast a series of talks, starting from Sue Johnson, who is the Professional Officer for Clinical Imaging, Society of Radiographers UK. And Sue will talk about prescribing role of radiographers to reduce risk. And next will be from Amanda Walsh. She's the Unit Manager for Field Course, Westmoreland and Wrightington MRI Centers, former contrast media specialist. And Amanda will talk on key considerations in the use of contrast media in CT imaging. And next speaker is our own Terry L., who is the Vice President for Americas of ISRT. He is a nuclear medicine technology specialist. And Terry will talk about preventing misadministration of radiopharmaceuticals. And next will be by Rex Christensen, who is the MRI Program Director, Weber State University School of Radiologic Science, ASRT Chapter Chair, from 2020 to 2022, and Rex will talk about reducing the risk of adverse effect of contrast enhancing agents used in MR imaging. And last but not least, our special guest from ISR QSA, Professor Donald Flutch, who is a Professor of Pediatric Radiology, Duke Health, Department of Radiology from Durham, North Carolina, USA, and Dr. Fresh will talk about pediatric imaging considerations. And let's watch very, very exciting program for today.
Hello, my name's Sue Johnson. I am a diagnostic radiographer working as a professional officer for the Society of Radiographers in the UK. The Society of Radiographers is a member organisation, and we're a trade union and professional body representing the interests of people working in clinical imaging, radiotherapy and oncology. I'm a radiographer of many years' experience, but over those years, I've seen lots of improvements to patient care. But perhaps one of the most impactful has been the legal change that allows radiographers to prescribe in the UK. So I've been asked to talk to you today about the development of radiographer prescribing within the UK and how this can improve patient access to the medicines that they need, help to reduce risks, and supports a focus on quality. You are going to hear how a UK radiographer becomes a prescriber and learn about our vision for a safe, high-quality, well-regulated future for patients to have prescribed medicines by radiographers. The story starts in 2005, when diagnostic and therapeutic radiographers were first legally entitled to become supplementary prescribers. That is, prescribing in partnership with a medical doctor using a clinical management plan for the medicines. That need has progressed though, and there is much more demand for autonomous practice and independent prescribing. More of that to come. There are many different medicines used in radiotherapy and diagnostic radiography. The management of prescription-only medicines, though, can be a challenge. In diagnostic radiography, contrast media remain the most commonly administered, with contrast media being defined as a medicinal product in both the EU and the UK. In the UK, additionally, within the medicines regulations, contrast media is classed as a prescription-only medicine because they're delivered via a parenteral route. That is, they are delivered otherwise than by way of the gut. In at least one state in the United States, though, contrast media are classed as medical devices. So understanding the legislation that applies to your practice is therefore essential to ensure compliance. Whether patients need medicines for the pharmacological effect or as a contrast media, this is often as a one-off or short timescale to support the diagnostic intervention or the therapeutic treatment the patient is having. For example, before and during a CT colonogram, or to manage symptoms of radiotoxicity during radiotherapy treatment. The knowledge of radiographic techniques and interventions sits firmly within radiology and oncology and radiographers. It seems therefore extremely logical that in the right circumstances, radiographers can take greater responsibility for managing these medicines safely. With the legal right to train as a prescriber comes significant responsibility. In the UK, those healthcare professionals with a legal entitlement to train as prescribers must be on a regulated professional register. For diagnostic and therapeutic radiographers, this is the Health and Care Professions Council, or HCPC, register. The HCPC ensures patient safety through the setting and upholding of safe standards for all radiographic practice. And this includes the standards of education and training that must be achieved by a prescriber. A radiographer who achieves the required education standards will have an annotation against their name on the publicly accessible register, indicating this responsibility. The HCPC standards for continuing professional development also require registrants to demonstrate reflection and ongoing development across their scope of practice, so this will include the prescribing role. We have 14 allied health professions in the UK, and 6 of them have prescribing rights. A prescribing radiographer must be working in a role where the multidisciplinary team and the employer agrees that their prescribing safely supports the patient pathway. They must be working at an advanced practice level. That is, they have considerable experience and expertise in the clinical area where they work. They hold a relevant postgraduate level qualification, preferably a full master's, and they have skills in education, leadership and research that supports their expert clinical role. All AHP non-medical prescribers, including radiographers, will study the same national curriculum, and they must attend and pass an education programme that's been approved by the HCPC. A designated prescribing practitioner from the area of clinical practice provides support, mentorship and training. This development of prescribing competence forms part of the education programme. In addition, there are profession-specific implementation guidelines published by the Society of Radiographers, and these detail the professional and governance procedures that must be achieved for safe prescribing. For example, the policies that must be in place, definition of the scope of practice, and any audit schedules that are going to be needed during the prescribing role. For all of the professions who prescribe, including doctors, there is one UK-wide single competency framework. Regardless of your professional background, this framework sets the standard and defines the process for good prescribing practice. All 3 of these main reference documents were developed by the Royal Pharmaceutical Society in conjunction with the relevant professional bodies that support the prescribing professions. Radiographers are expected to take note and follow professional guidance in their practice. This is the gold standard against which prescribers are measured. Millions of patients worldwide every day attend for imaging procedures and therapeutic interventions that will include medicines. All medicines and interventions come with risks. For many prescribed medicines, there can be significant and various side effects, especially for those patients undergoing chemotherapy and radiotherapy. Unfortunately, this means that every day, someone, somewhere, will have a catastrophic reaction to a contrast agent or an unexpected response to another medicine used during their imaging or radiotherapy intervention. These side effects and reactions need managing, and often quite swiftly. Access to radiologists or oncologists is reduced. There's a global workforce crisis and increased patient demand. New ways of working are also impacting, especially in the recovery period from COVID. Some radiologists may be reporting from their homes, or patient consultations are taking place using video calls, making access to an appropriate prescriber even more challenging than it was just 2 years ago. A prescribing radiographer within a department increases the availability of a suitably trained professional to assess a patient suffering from a side effect or a reaction and put an appropriate intervention in place, which may be a prescribed medicine. Well, I think it's universally recognised that best practice requires an individualised approach to our patients, and prescribing is no different. A prescriber can take account of the patient's preferences, their personal characteristics, their current care plans, comorbidities, other drug interactions, and any desired outcomes. The preferred way for patients to access prescription-only medicines, indeed all medicines, is to have them prescribed, although other mechanisms are probably more often used. Therapeutic radiographers prescribe across a complex range of areas within the field of radiotherapy and oncology. For example, they may develop expertise as an advanced practitioner in a single tumour area, e.g., a lower GI tumour. They are a key part of the multidisciplinary team of doctors, nurses, pharmacists, and other professionals who are supporting the patient through their radiotherapy regime. As part of their on-treatment review, they will assess their patients for appropriate medication, seeking information about pain or other symptoms that are associated with the treatment and disease pathway. They can and do advise and prescribe medicines, e.g., loperamide hydrochloride for radiation-induced diarrhea, or Sceriproct ointments for anal skin reactions due to diarrhea. They may also prescribe antibiotics for a simple urinary tract infection, or order biochemical investigations, assessing results and adjusting prescriptions while having full awareness of the impact of radiotherapy and chemotherapy on the body systems. Some therapeutic radiographers may even prescribe chemotherapy and manage blood transfusions and their associated processes. The therapeutic radiographer can give the patient the necessary information that links to their treatment for them to make an informed choice. They can ensure that the patient remains central to their discussions and any new regime meets their needs. They will discuss any changes to medicines with the patient and give advice and guidance, including de-prescribing where medicine is no longer needed or working as expected. They record the medicine plan on the patient record and they communicate this to other healthcare professionals as needed. The patient is getting advice from an expert on their treatment pathway. They don't have to wait for a hospital doctor to come and prescribe, nor do they have to go to their general practitioner for a prescription, something that often causes delays to treatment. Independent prescribing isn't quite here yet for diagnostic radiographers, but we do have a vision. Supplementary prescribing hasn't really worked that well for diagnostic radiography. The interactions are too brief, and the lack of continuity of care makes a clinical management plan almost impossible to develop. However, When we have independent prescribing radiographers who have been trained through the same education and training as the other non-medical prescribers and who are working at that advanced practice level, we can see that there will be many opportunities to improve patient care. For example, within a busy CT or an MRI department, there are often patients who need an independent prescriber to advise on the suitability for them receiving a contrast agent. These are patients that fall outside of the criteria against which a non-prescribing radiographer can already administer the agent. This can cause delay. It may also mean that the patient is being assessed remotely by a radiologist having information relayed by a radiographer, or the patient even may have to be rebooked. An advanced practice radiographer trained as a prescriber can assess the patient as an individual on a one-to-one, face-to-face basis, advising and discussing the appropriate intervention with the patient. This reduces delays, supports decision-making with the patient, and increases safety, as the radiographer is on hand to manage the patient through the medicine administration. Should a patient react to a contrast agent, an appropriately trained prescribing radiographer based in the scan department can assess the patient and make appropriate prescribing decisions to manage the situation very swiftly. In interventional radiology, advanced practice radiographers are performing some of the less complex interventions, such as tube insertions or changes, or managing vascular access. These patients also need medicines, such as local anaesthesia or pain relief, but it's very much based on their needs at the time of the procedure and depending on the nature of the procedure. A prescribing radiographer can bring the required medicines knowledge to the intervention. Current practice is really less well regulated and unfortunately much more ad hoc. In MRI, some patients need support with anxiolytics to have their scan. Currently in the UK, we don't really have a good system for managing these patients appropriately. Patients can be sent backwards and forwards to the referrer or their general practitioner, and that can cause significant delay to them actually getting in for their scan. This is one area where radiographers appropriately trained to prescribe for this condition can have a significant impact on patients' access to their diagnostic tests in a timely manner. Advanced practice radiographers also work in places like bone density services, breast units, or minor injury units, where they're assessing patients with their imaging results. Currently, they must refer the patient to another practitioner for them to receive any medicines that they need for any condition that they have diagnosed. Once trained to prescribe, they will be able to see and treat, discharging the patient or referring on as needed, knowing that the patient has immediate access to the required medicines. There are multiple other examples. I'm sure you can think of many too, such as CT colonography for prescribing bowel cleansers, or cardiac imaging for managing heart rhythm and rate. So as a professional body and an individual, the SOR has contributed to and published many guidance documents to support the development and implementation of independent prescribing into radiographic practice. These documents are based on evidence and the insight of our prescribing radiographers. They will be updated over time as new evidence to support safe practice is published. The SOR has stakeholders in research, assessing the clinical and financial impact of this role development, and we look forward to sharing further impact assessments as radiographers' roles evolve. In short, the SOR believes that diagnostic and therapeutic radiographers are ideally placed to become experts in an area of radiographic practice that is then enhanced by holding a relevant prescribing qualification. This gives patients access to additional experts in the team who can prescribe medicines related to their clinical pathway, help to reduce delays, and support safe, person-focused care. Thank you very much for listening.
Hello everyone, I'm here to talk about the key considerations in the use of contrast media in CT imaging. I'm a diagnostic radiographer and have been involved in CT for many years. So I hope you find this 15 minutes very informative. Just to take it back to basics, obviously we all as radiographers and technologists and people involved in radiology use contrast media, but we don't use it very often and think about it. It's just part of the procedure. And I feel that we need to give it a little bit more thought. So basically, this is what that presentation's about. So obviously, contrast media is a substance placed in the body to provide added contrast when the subject contrast is low, as in our abdominal organs. And obviously, it'll increase the difference between the areas containing contrast media and not containing contrast media. A little bit of history about it, because it's been around an awful long time. It was first sort of reported during a GI contrast study in 1897, but they used bismuth, which is highly toxic, but there was some difference between abdominal organs seen. So that's where it was first reported. Then in about 1910, barium sulfate started to be used, which was obviously much safer to the patients. In 1920s, sodium iodide was used to treat syphilis, and as a byproduct of this, it was shown to show up on X-rays. So that was started to be used. And iodine was found to be radiopaque to X-rays, as I just said. And this is still the basis of all modern X-ray contrast agents. And in 1927, the first reported IVU was done with iodized organic cells, and that name was uroselectin. There's three main classes of iodinated contrast media: the high osmolar ones, the low osmolar ones, and the isoosmolar ones. Generally in the UK and probably in many countries around the world, the vast majority of us now use low osmolar contrast media. The high osmolar ones were had a very high osmolality, so they changed the osmolality of the blood, and there was a lot of exchange of fluids between plasma and the blood cells, which isn't great, as you know, and can cause lots of things like shock and lots of reactions. And there was high rates of nephrotoxicity. Fortunately, they've been superseded by products now that have very low osmolality, so very similar to blood. They've got low viscosity, which is good, lower rates of nephrotoxicity, and it's, as I just keep saying, it's the most common class to be used in clinical practice. I put some of the brand names there: Optiray, Xenitex, Omnipaque, Niapam, Iamir, and Ultravist, depending on where you are in the world and what is your radiologist's preference. The other class are the isoosmolar contrast media, which is pretty much Visipaque, and they have the same osmolality, pretty equal to that of blood. So, in fact, they're the ones that should cause the least reactions to patients who have an injection of contrast media. But because they're 6 iodine atoms instead of the low osmolality ones, which are 3 iodine atoms, they tend to be much more viscous, which causes lots of problems in different ways. But again, a bit like the low osmolar contrast agent media, they have low rates of nephrotoxicity. So those are the 3 main classes that are available these days. This is probably the most important slide. When you're doing CT, you really need to be giving a little bit more thought to the contrast media than as we do in the UK, or as we have done, 3 mils a second for 100 mils, regardless of anything. So the patient factors that I think are really important are thinking about the target organ, so where you want that contrast to be visualized, the magnitude of the patient, so the weight of the patient, the height of the patient, patient's cardiac output, the age, and the gender. The easiest way to look at this is the weight of the patient, but I'll talk about a little bit about that a little bit further on. Timing's really important if you're thinking about optimizing contrast media, and the breath holding, the comorbidities of the patient, and obviously renal function, EGFR, things that we do anyway. In terms of the CT scanner, I'm sure across all of the countries that are watching this day, there are multiple versions of CT scanners, but you really need to be thinking about your CT scanner. How many slices did it start? How fast is it? Are you going to use a scan delay, bolus tracking, test bolus? Is it a multi-phase scan? Is it ECG gated? All of those things. So it's really important that you think about your CT scanner as well as your patient. And then finally, but no less important, obviously, today is the contrast medium factors. So it's the concentration and the volume of the contrast media that you're giving, the rate that you're giving at, and whether you're following it with a saline flush. And obviously these days, most of us are using multi-patient injectors, so using large volumes of contrast media and following every time with a saline flush. So looking at the timing of the injection, the viscosity of the contrast media, and whether you're doing a single phase or a biphase, or in some cases you can use software to exponentially decay the flow rate of the contrast media during the injection. So lots of things that could make it very complicated. But basically, the best thing to do is weigh your patient like you do for MR and use a certain amount of contrast media per kilogram. I'm not going to suggest that because it's different in each country, depends on your radiologist, but there's plenty of information online where you can look at weight-based dosing. And also, don't use the most highest iodine concentration contrast media all the time. Think about your KVP. If you lower your KVP, you get brighter contrast. So there's lots of things that are important when you're thinking about giving a patient an injection of contrast media. It's not the 3 mils a second for 100 mils. We should be taking into consideration an awful lot of things. And again, if you're using the multi-injection size contrast media packets like 500 mils, you can optimize the amount of contrast media that you give really easily. And not importantly, but importantly, in this day and age, it's a cost saving, so you're not wasting contrast media. And in our country, we've had a lot of problems getting contrast media. There's been an iodine shortage. I'm sure it's the same in all of your countries. So anything you can do that can help optimize the amount of contrast media you give to the patient for their benefit will also benefit your department in terms of less wastage and eventually some cost savings. So the weight of the patient can affect the way that you can see contrast media in a scan. So in this graph, you can see that there's different weights depending on the colours. So the lightest person is the black dots and the heaviest person is the blue line with the crosses. And you can see how the aortic enhancement will increase with a smaller patient with the same volume of contrast media, approximately at the same time after the injection. Now, there is a window of Hounsfield units where you can still get diagnostic information. So do you need to give that 50 kilogram patient the same amount of contrast media as 125? No, you don't. You could give less. Again, the same in the liver. If you give the same amount of contrast media, you can see that you get much brighter, as you would imagine, a hepatic enhancement in Hounsfield units with the lighter patient than you do with the heavier patient. So that means you can bring down the volume of contrast media that you give to the 50 kilogram patient as opposed to the 125 kilogram patient and still have enough Hounsfield units for it to be diagnostically accurate. So you can look at multiple phases, whether you're looking at the arterial phase, portal venous phase. This is all going to have impacts on the Hounsfield unit enhancement. And that's just different contrast strengths. So the same weight of patient, but on this time we're looking at different concentrations. Again, obviously, if you use the higher strength of 400 milligrams per mils, you're going to get brighter Hounsfield units in the aorta as opposed to the 300. But if you're happy with above 250 Hounsfield units enhancement, you don't need to use the 400. So it's a trade-off all the time. reducing the amount of contrast media, optimizing the delivery rate, optimizing the strength, but ensuring that it's still diagnostically accurate and you're going to get the best diagnosis for your patient, and that your radiologist or your radiographers are still happy with the images and obviously the radiologist report. Similar in the liver as well. So again, really important to think about the contrast media strength as one of those factors. And that's just the same thing in the aorta. So obviously, contrast media has evolved over the years. It's gone from being a very poisonous substance with very, very low resolution CT scanners up to, even urographic now isn't very modern, but to much more modern, safer for the patients, contrast media. So the contrast media has evolved, and now it comes in very big bags up to about 1,000 millilitres. So a litre of contrast media, I believe, is available now. So that means you can use, as I keep saying, it against the weight of the patient, and you can optimise the contrast delivery for each patient. So that part of it's evolved. CT's evolved. It's gone from very old-fashioned head scanner to something completely different. And you can see on this very old head CT slice where you can almost count the pixels of the brain scan, even though you can actually see that there is some pathology here. It's surprising how far it's come. So your CT is evolving, and we've always used quite simple contrast procedures in the beginning, and it was single slice CT scanners, low throughput. We'll use lots of hand injections historically. We didn't have pressure injectors. We used to have tons of reactions. And the timings for a thorax, abdo, and pelvis was start the contrast media and start imaging 30 seconds after the start of the contrast. And then for the second part, for the portal venous was 60 to 70 seconds. So then multi-slice CT scanners evolved and came on the market, faster, much more complex procedures, higher throughput of patients, starting using pressure injectors with low osmolar contrast media that I talked about at the beginning. So loads less reactions than there used to be. But the timings for the thorax, abdomen, pelvis, 30 seconds delay after the start of the injection. And then for the portal venous phase or abdomen and pelvis, approximately 60 to 70 seconds. So you can see it's still the same contrast media timings, even though there was a lot of evolution in the CT scanners. So now we're looking at 64 slices and above, multi-slice CT scanners, faster again, new procedures coming into CT. Many of you will be doing cardiac CT as a routine. Many of you will be doing colons, very complex procedures, and still using a lot of the same timings that we did right at the beginning when we were doing hand injections. So it's time for people to start considering the contrast part of the procedure for the patient, as well as the CT as the hardware. So there's many fancy scanners on the market now. There's spectral, looks at photons of high energy, the iterative model reconstruction. So they're using much less radiation. So again, with the less radiation, you want to be thinking again, less contrast media again, and the spectral definitely allows you to do that. Again, the Toshiba one. And radiotherapy, we're starting to use quite a lot of contrast media in radiotherapy scanning, and they're wide bore scanners. So radiotherapists do some form of contrast media training, but not like diagnostic radiographers. And they do tend to get their protocols from the adjoining diagnostic department. They need education. They use a lot of, this Opti1 was just a contrast only injector, so no chance to do saline chasing. And we need to talk to them about lower volumes of contrast media. So it's not only in the diagnostic department, It's in the radiotherapy department where contrast is becoming to be used all the time. So there's lots of education needed, lots of thought needed. And as diagnostic radiographers, I think it's our duty to help educate the radiotherapy departments and mammography as well. They're starting to use contrast media more and looking to buy injectors. So again, that's another division of our field that could do with some education on contrast media delivery. So just to reiterate, you've got all your input variables, which again are the patient weight, height, gender, the injector and the CT scanner. All of those things are the inputs. And then you've got your clinical goal, your injection duration, rate, scan delay, and all of these things will help with the optimal enhancement and the accurate diagnosis of your patient's CT scan. So obviously the things that we've talked about are on the left, and they'll all impact on how it looks at the end. So hopefully, even though it's been a very quick 15 minutes, and I hope I've managed to speak clearly and concisely, you'll end up thinking a little bit more about contrast delivery. You'll think a little bit more about volumes of contrast, rates of flow, the impact the contrast has on the patient, and maybe start weighing your patients and doing some weight-based dosing. And you'll end up with some amazing end results from your CT scanners. Thank you very much for your attention. It's been a pleasure.
Good day, everyone, and happy Patient Safety Day. Welcome. My name is Terry L., and I am the ISRRT Vice President of the Americas. Administering radiopharmaceuticals and often other drugs is a common everyday practice for every nuclear medicine technologist. As a long-time nuclear medicine technologist, my fear is that sometimes we may become rather too complacent in performing this essential activity and not recognize the potential harm to our patients when we do not follow optimum practice techniques. In that light, I would like to review with you some best practice administration techniques in the hopes that we can ensure that our patients are receiving optimum patient care. The basic safety standards on radiation protection and safety developed by the International Atomic Energy Agency direct us towards the need to limit the chances of accidental radiation exposures during medical procedures, and in the unfortunate circumstances of such an event, the requirement to investigate and take corrective actions to limit the effects of the error. Certainly, misadministrations adversely affect the healthcare system and the radiographer, including increased healthcare costs, extra work and stress for the practitioner, and loss of faith in the technologist and the system as a whole. But worst of all are the consequences for our patients which can be devastating, particularly when dealing with therapeutic doses. This administration of radiopharmaceuticals should not be characterized as random human errors. The initiating event and the contributing factors can always be identified. Most misadministrations are caused by a combination of several contributing factors. As seen here, many may be attributed to this overall system and not under the direct control of the radiographer. Certainly, the radiographer bears substantial responsibility for minimizing misadministrations and ensuring patient safety. I'm sure we have all encountered situations in which a heavy or stressful workload has caused us to be distracted, hurried, and perhaps even to cut corners to keep up with our busy schedule. Indeed, data from as far back as the 1980s demonstrates the impact that the actions of the radiographer can have on this issue. A more recent but still dated study out of Australia reveals that the situation is hardly improved. Given that it is the radiographer who generally administers the dose, it is apparent that the radiographer is instrumental in preventing such use. I would like to quickly review what I call the radiopharmaceutical administration rights of the patient. While I know that these practices might seem quite basic, I would challenge you to consider whether you practice each one every time you administer a dose to every single patient. Perhaps you will find a step that could improve your own patient safety strategy. Let's start by ensuring the right patient. How do you ensure that you have the correct patient? Do you ask the patient for their full name and require 2 forms of identification? Do you match the ID band of the inpatient with the requisition? A step that I have found useful, but not always implemented, is to have the patient verify that the name on the labeled dose is their own name. Do you only administer a dose after completely reviewing the requisition? Do you question the patient about their symptoms? Does the requested procedure seem to fit with the history provided by the patient? And if not, or if you are unsure, do you bring it to the attention of the supervisor or radiologist prior to continuing with the test? The basic safety standards require that appropriate signage be clearly available to the patient and in a manner that the patient understands. Are you following all departmental policies to ensure that the patient is not pregnant or lactating? If there is any level of uncertainty, what steps are you taking prior to continuing with the procedure? What about the right radiopharmaceutical? How do we ensure that the correct radiopharmaceutical is being administered? Make sure that the type and dose radiopharmaceutical matches the test requested by the referring physician. Once the dose has been drawn up, make it a standard practice to have a colleague sign verification of the radiopharmaceutical, including lot number, expiry date, and dose. Label the dose with the patient ID and use a color code system to distinguish between various radiopharmaceuticals. I understand that during busy times, there may be an inclination to save time and try to be efficient. However, doses should be prepared just prior to administration. Do not draw up multiple doses in advance, particularly of various agents. Ideally, the person drawing the dose should also be the one administering the radioactivity. For those of us who image both adult and pediatric patients, be aware of the differences in doses so that there is no confusion. We all recognize the need to administer the correct dosage of radiopharmaceutical. On occasion, to stay on schedule, we might be tempted to top up the dose to speed up the scanning time. However, exceeding standardized dosages unnecessarily exposes the patient to excessive radiation, particularly in the case of a therapeutic radiopharmaceutical. Reducing the dose from optimum standards may also impair image quality and diagnosis or require that the study be repeated, which of course would also increase exposure to the patient. For diagnostic radiopharmaceuticals, a variation of plus or minus 25% from the prescribed activity is generally considered acceptable, but you obviously need to follow local guidelines. A discrepancy of 10% from the prescribed dose in therapeutic applications is generally considered reportable. Recognize that even when individual doses are within an acceptable range, multiple repeated dosing also has potential of delivering a substantial effective dose equivalent. A number of steps should be taken to ensure the correct activity is administered. We need to make sure that the dose calibrator is properly calibrated by always performing appropriate daily quality control procedures. It's not a bad idea to assess the calibration throughout the day as well. Check that the calibration factor is correct for the isotope being measured. On the right, you will see the significant effect the calibration factor has when assaying the sample. Experienced radiographers generally have an expectation of the volume for a particular dose. If the measured activity seems atypical, double-check the isotope setting. Always measure the activity just prior to use, particularly if the dose has been drawn up in advance. What about the right route? Most of our radiopharmaceuticals are administered IV. However, several can be administered in more than one format, usually as different activities. For example, DTPA can be injected for a renal scan, but also aerosolized for a lung ventilation study. We must check the requisition to ensure that the radiopharmaceutical is being administered in the correct form for the study. A comment about inadvertent interstitial injection. Interstitial injections cause the patient unnecessary discomfort and reduce the quality of the scan. Additionally, the absorbed dose can be substantial, particularly at the injection site. Therapeutic doses are particularly devastating. Always double-check the patency of a line and flush after administration. We may often not consider our patients' needs when determining the timing or frequency of our study. But what about the right time and frequency? After all, we have a schedule to keep and a requisition for this study on this patient, right? But wait, several issues may impact when or how often we image a patient. Has this study been completed previously, either at our institute or another? Does it really need to be repeated? If so, is now the best time to perform this study? Do we have the results of earlier scans or previous studies for review and comparison? Are other tests booked that should be performed first? For example, an ultrasound study may negate the need for our imaging, and it might be a professional courtesy to allow the ultrasonographer and the ultrasound to be completed first, when possible, to limit the radiation exposure to our sonographer colleagues. Are there any contraindications for the study at this time? This may include potential interference by previous medications. For example, has morphine been administered prior to a hepatobiliary exam? Are there any dietary restrictions that may interfere, such as in the case of gallium imaging? Have other procedures been performed that may affect the study, such as the presence of barium? A complete and accurate history is absolutely essential prior to commencing any study. Requirement 37 of the Basic Safety Standards states that the radiographer, in consultation with the radiologist or referring physician, must be able to justify the study in question. Here I'm going to suggest a step that I have come to understand is somewhat controversial in some jurisdictions, but I submit to you that it is our responsibility to question the order if we suspect that the orders are inappropriate for a particular patient. As the last healthcare provider to speak to the patient, the radiographer must ensure that the study is appropriate for the signs and symptoms presented by the patient. The radiographer is obligated to address any inconsistencies that may arise between the information provided to the patient and the orders through a thorough discussion with an appropriate authority. To perform a procedure simply because we have an order does not justify performing the procedure that does not fit the patient's condition. It is essential that the radiographer be prepared to provide the patient with an understanding of the procedure, including potential therapeutic and side effects, in a manner commensurate with her abilities to comprehend and consent in an informed manner. The topic of informed consent requires a full webinar in itself, but some issues to consider would include the use of scientific terminology, the nature and purpose of recommended interventions and the burdens, risks, expected benefits of all the options, including foregoing this procedure. After an explanation of the test to the patient, we often ask, "Do you have any questions for me?" The patient usually responds simply, "No." That may be because they do understand, but sometimes it can be because they are embarrassed to ask questions or don't know what questions to ask. One way that I have found to ensure their understanding is to ask them to repeat in their own words what I've explained to them. That way, I can be assured that they have interpreted my explanation correctly and are prepared to follow my direction. Special considerations must be applied when dealing with children, those who do not have the full capacity to consent, and those who do not speak the local language. Of course, the patient also has the right to refuse the procedure at any time. However, should they do so, we want to ensure that they understand the consequences of the refusal and fully document, as best we are able, when and why they chose to leave. At times, I have found that having another radiographer take over and connect with the patient very helpful in terms of achieving a patient's understanding and consent. And of course, the referring physician must be appropriately notified. Well, thank you for your interest in this key patient safety issue. I hope this has served as an important reminder of best practice administration techniques. You may even have picked up a couple of pointers. Remember, patient safety is in your hands. Thanks again, and hope to see you in Bangkok. Take care.
Hi, my name is Rex Christensen. It's an honor to speak at the ISRRT World Patient Safety Day. My presentation is going to be about reducing the risk of adverse effects of contrast-enhancing agents using MRI. I live in northern Utah in the United States. Here are my disclosures about my employment and my volunteer positions. The objectives or the questions to answer for this presentation are as follows. What is gadolinium and the mechanism for delivery? What are preventative measures to reduce adverse events? What are some special considerations when administering gadolinium-based contrast agents? And what do we do now? So what is gadolinium and the mechanism for delivery? MRI contrast is a gadolinium-based contrast agent, or a GBCA. You'll hear that term a lot in this presentation. What is gadolinium? Gadolinium is a rare earth metal. It is represented by the symbol GD, and its atomic number is 64. Gadolinium is a heavy metal that has a +3 charge with 7 unpaired electrons. These unpaired electrons attract nearby protons, such as water. And how does that work? Because gadolinium has this strong paramagnetic property, it gets excited in a magnetic field. The relaxation times of nearby protons in a magnetic field are low in concentrations and to provide enhanced image quality. So what it does is it shortens the T1 relaxation time, which makes those protons recover faster along the longitudinal direction. Because of this faster longitudinal recovery, gadolinium aids in the visualizations of tissues within the body. And so what is the structure? If we look at it this way, we have gadolinium in its raw form, in its heavy metal form, and we have a chelate or a ligand. And those two together equal a gadolinium-based contrast agent. I like to use the analogy of a peanut M&M. So you have a peanut on the inside, that's the gadolinium, and then on the outside you have the chocolate, that's the shell, and that's the chelate. And so we think of it in those two terms. The peanut is the gadolinium again, and the chocolate covering is the chelate. And then we have the structure of that chelate. So that chocolate covering on the outside has two different types of structures. It has a linear, or it could be macrocyclic. So I have two examples here showing on the left a linear agent and on the right a macrocyclic agent. And here's the peanut. So the gadolinium is in the center of that. So the GD, you can see the GD3 plus, that's going to be the gadolinium, the peanut that's in the center. And then that's the one on the left is for the linear agent. And then you can see for a linear agent, it's going to be more, that outer covering is going to be more straight. And then for macrocyclic, you can see how it's a circle that kind of covers and goes all the way around the gadolinium atom. We have ionicity, or the charge of gadolinium. So if it's ionic, it has a charge. If it's non-ionic, it has no charge. So here we have some different examples of different contrast agents. The brand name is on the left, and the chemical name is in the middle, and then the structure is on the right. So on the left, you can see the different brand names there. In the middle, you can see the gadolinium. And then on the next to that, you can see its chelate or its ligand. Okay, so what does this mean, or how does this apply to contrast reactions? The ionicity and the structure of GBCA determine its stability. So it's dissociation between the gadolinium and the chelate. So ionic gadolinium-based contrast agents have a tighter bond than non-ionic contrast-based contrast agents, or gadolinium-based contrast agents. Macrocyclic gadolinium-based contrast agents have a tighter bond than linear gadolinium-based contrast agents. And so again, going back to the peanut M&M, if you look at the breakdown of that outer shell, of that chocolate shell, if it's an ionic, it has a tighter bond. If it's a macrocyclic, it has a tighter bond than the non-ionic versus the linear. So our mode of administration, how do we administer it? We administer it intravenously. 0.1 to 0.2 millimoles per kilogram is typically what we administer. If we're going to do intra-articular, these are just some protocols as far as how to mix the gadolinium if you're going to do an X-ray guided injection versus an ultrasound guided injection. And you can see that the gadolinium amount is relatively small in that intra-articular administration. So what are some preventative measures to reduce adverse events? So we have to look at the adverse events as far as in hours, which are going to be acute, and then over 24 hours, which are going to be chronic events. So with adverse events that are shorter, the GBC administration rate at clinical doses, again, 0.1 to 0.2 millimoles per kilogram. For an adverse rate, it ranges from 0.07% to 2.4%, so relatively low. Most reactions are mild and physiologic, which includes coldness, warmth, or pain at the injection site, nausea with or without vomiting, headache, paresthesias, dizziness. Allergic reactions are uncommon and vary in frequency from 0.004% to negative 0.7%. And then severe life-threatening anaphylactic reactions occur but are exceedingly rare and range from 0.001% to 0.01%. So what are some of the risk factors? The frequency of acute adverse reactions to gadolinium-based contrast agents are about 8 times higher in patients that have had a previous reaction to a gadolinium-based contrast agent. So corticosteroid prophylaxis protocols prior to GBCA administration is recommended for those individuals, or using a different GBCA agent. So if you're using one particular contrast and you have a reaction to that, or the patient has a reaction to that, don't use that agent again. Asthma and various other allergies have mild increased risk for an allergic reaction, and there really is no special procedures for these patients considering the reaction rates are relatively low. So what are risk factors for chronic adverse events? We have gadolinium toxicity, which includes nephrogenic systemic fibrosis, NSF, and gadolinium deposition disease, or GDD. So let's talk a little bit about gadolinium toxicity. In September 2017, the U.S. Food and Drug Administration, the FDA, and the Medical Imaging and Drug Advisory Committee, the MIDAC, voted to recommend new labels on gadolinium-based contrast agents, warning of the possibility of gadolinium retention in the body. In 2017, the European Union removed the GBCAs with a linear structure for general use from the market after a 3-year multi-stage evaluation process. And these two contrast agents, they are linear, but they are actually approved for these specific uses. So Magnevis is approved for intra-articular studies, and Multihance is approved for liver exams by the European Union. Let's talk a little bit about nephrogenic systemic fibrosis. This presents with cutaneous thickening and discoloring of skin, affecting the limbs and trunks, but sparing the face. In 2006, there was a possible link that was identified between gadolinium-based contrast agents and NSF. This is a really good description of the ACR categorized the contrast agents into 3 different groups: Group 1, Group 2, and Group 3. In this article this year, entitled Gadolinium-Based Contrast Agents, Updates and Answers to Typical Questions Regarding Gadolinium Use, the authors took those groups and they categorized them using, on the vertical axis, ionic versus non-ionic, and then on the horizontal axis, cyclic versus linear. And then they color-coded them to show the different groups. So Group 1 is red. This was associated with the highest number of cases of NSF. Group 2 is green, and this was associated with few or no cases of NSF. And then the yellow group, which is Group 3, is associated with only a few administrations with no unconfounded cases of NSF. So let's talk about Group 1 and 3 GBCAs. Patients receiving Group 1 GBCA should be considered at risk of developing NSF if any of the following conditions apply to the patient. So if they are on dialysis of any form, they should be considered at risk. If they have severe or end-stage chronic kidney disease, they should be considered at risk. Or if they have acute kidney injury, they should be considered at risk. We have to talk a little bit about eGFR. So for outpatients who may be receiving Group 1 or Group 3 agents, they should be screened for conditions and other factors that may be associated with renal function impairment. So one of the things as technologists, what we simply have done for many years is we just say, well, so how are your kidneys? Your kidneys function okay? And that's not an effective screening tool to do that. So what they recommend is that you use these panel of questions that actually delves a little deeper into the patient's history. So does the patient have a history of renal disease, including dialysis, kidney transplant, if they have a single kidney, if they've had any kidney surgery, if they have a history of known cancer involving the kidneys, or a history of chronic kidney disease, or a prior history of acute kidney injury, or a history of diabetes. Now let's talk a little bit about gadolinium deposition disease. So in 2014, there was a published research of high signal intensities in the dentate nucleus and globus pallidus of the brain. And on the basis of the global use of GBCAs, different countries have implemented various strategies for that. And here's what we know. There is convincing evidence available for the deposition of gadolinium in the deep nuclei of the brain, particularly after repeated exposures to gadolinium-based contrast agents. Several studies, human and animal, show differences in gadolinium deposition that there are apparent among different MRI contrast agents. Further research is needed in order to gather more reliable data, and the International Society for Magnetic Resonance in Medicine recommends to attempt to balance the potential yet unknown harm of gadolinium deposition with proven clinical and research utilities of GBCAs. So the FDA stated there's no clinical evidence that directly links gadolinium retention to adverse health effects in patients with normal kidney function. And the FDA has concluded that the benefits of all approved GPCAs continues to outweigh any potential risks. I know that varies from different countries as well. So that's the FDA here in the United States. So what are some special considerations when administering GBCAs? So let's look at pediatrics, pregnant women, breastfeeding women, and patients with chronic kidney disease. So for pediatrics, there are only a few published studies that address adverse reactions to gadolinium-based IV contrast media in children. And these are some of the studies, and you can see that they show relatively low percentages there. Based on the number of injections, the first one has 0.04%, and then the second one has 0.05% as far as allergic-like reactions. So there's no evidence-based guidelines for the prevention of NSF in children in particular. The ACR recommends that adult guidelines be followed for identifying at-risk patients and administering gadolinium-based contrast media in the presence of impaired renal function. Caution should be used determining the risk versus the benefit when administering these GBCAs, especially to preterm neonates and infants. What about pregnant women? So the ACR pregnancy screening statement states this: the current standard of practice is to avoid routine contrast administration, gadolinium-based contrast administration during pregnancy due to the unknown risk of fetal exposure. And they recommend that imaging facilities have an established standardized system of screening in place that includes screening for unsuspected pregnancy prior to gadolinium-based contrast administration. What about breastfeeding women? So what they know is that when a woman is breastfeeding and they are given contrast, that the milk that is the amount of gadolinium that's in the breast milk is 0.0004%, very low. So what they recommend, they say it is safe for a mother and infant to continue to breastfeed after receiving such an agent. But ultimately, an informed decision to temporarily stop breastfeeding should be left up to the mother, and after these facts are communicated to the mother. If the mother remains concerned about any potential ill effects to the infant, she may abstain from breastfeeding from the time of contrast administration for a period of about 12 to 24 hours. So your facility or your institutional protocols will determine what you want to do and based on that information. Patients with chronic kidney disease. So what do we do for that? So the ACR Committee on Drugs and Contrast Media recommends if a contrast-enhanced MRI examination is to be performed in a patient with end-stage renal disease on chronic dialysis, injection of a group 1 agent is contraindicated, and the committee recommends the use of a group 2 agent. The ACR Committee on Drugs and Contrast Media and the National Kidney Foundation also recommend that in patients who are already receiving dialysis, if feasible, elective GPCA enhanced MRI examinations be performed before regularly scheduled dialysis. So get the exam right before you're going to have your dialysis exam. All right, what do we do now? Radiologists should always approve all gadolinium contrast exams to ensure that they are justified and protocoled exams accordingly. They need to address patient concerns about GBCAs if there are any, reduce the frequency of the GBCAs to the same patient, so we're not doing multiple contrast exams over and over and over again unnecessarily. Document the administration of those gadolinium-based contrast agents for all contrast study. Document the type of contrast-based gadolinium-based contrast agent, the amount and route administered, the lot number, the expiration date, and if the patient had any type of reaction, mild, moderate, severe. And this should be put in the patient's electronic medical record, or EMR. Another thing we need to do is promote the need for a patient registry to document adverse reactions to gadolinium-based contrast agents. We need to gather data. And so we need to promote a universal database to be able to gather data so we can learn more from that data about these different contrast agents. So in summary, here are my recommendations. Review your gadolinium-based contrast agents, your policies and procedures at your facilities. Discuss those policies and best practices with your radiologist that minimize the risk of adverse events to the patient. Document the type of gadolinium-based contrast agents, the amount, route, administration, lot number, expiration, adverse events in the patient record, and then continue to follow updated information regarding MRI contrast agents. Thank you for your time and your attention. Here's my contact information at the bottom if you'd like to contact me regarding any of this, and here are my references. Thank you so much. Enjoy the rest of your conference.
Hello and welcome to the ISRRT, ISR QSA World Patient Safety Day webinar. It is really quite a privilege to be here with the other presenters, as well as the esteemed panelists and hosts today. I will be discussing SAFE as it relates to pediatric CT. First of all, we must remember that CT, as well as other imaging modalities, is very valuable and can be quite life-saving. For example, here is a contrast-enhanced CT examination of a young man, and I've circled the areas where there was contrast extravasation from the right leg, the left leg, the right arm, and actually intraperitoneal here. This is an example of how CT can be life-saving in this individual who was in a motor vehicle accident on this motorcycle and actually caused the damage to this truck here. Now, he is walking fine, had his helmet on, but we must remember as we go through and talk about the safety issues with CT, especially radiation, that we remember the value, and I'll emphasize this throughout. It's also important to realize sort of the approach of CT examinations, and while I won't talk specifically about the nuances, perhaps the tactics for reducing dose, et cetera, I will give you references along those lines. I want you to understand that the care of children is quite different than the care of adults, and I've listed here many of those kinds of issues. For example, large range of sizes, variations in anatomy, variations in physiology, different disorders, different manifestations of similar disorders, et cetera, et cetera. But the one thing to remember is in the care of children, we're dealing with a unit. We're dealing with caregivers and with families, and our approach, our perspective on this needs to consider these different aspects in the care of children. And again, I'll emphasize that when discussing the communication aspect of this presentation here. To this end, it's important to realize, as exemplified here in a CT examination with the mother here with this sedated child, that why caregivers feel this way. There's a lack of control, helplessness really, an unfamiliarity with the surroundings in the medical environment. These individuals, again, are making decisions for others. There's high anxiety and there's a sense of urgency. And what are the potential consequences of what we do? For example, as I look in from the control area, why are you here? You weren't here last time. What does this mean for my child? And that's quite different than adult care. And as we go through and talk about pediatric CT safety, I'll talk about the radiation approach and discuss a few issues with respect to IV iodinated contrast administration. First, and it's very important to recognize as we become familiar with equipment, as we apply various strategies for dose maintenance, dose reduction, et cetera, that we cannot sacrifice diagnostic quality for radiation dose. And here's an example. Now it's an abdomen pelvis contrast enhanced CT examination. And as you can see, the overall dose for a pediatric abdomen CT is relatively high, 11 millisieverts, whereas we usually target maybe 5 to 6 millisieverts. And there are 3 phases we did here, which is somewhat unusual, but it was very important. This child has dermatomyositis, and you can see extensive calcifications, both in soft tissues as well as intraperitoneal. And this child was having a significant GI bleed. The arterial phase here identified an area of contrast that appeared and persisted in the venous phase. That would be quite difficult if we didn't have the pre-contrast examination to define that. and in fact led to correct embolization of 2 areas of acute bleeding here, which fundamentally saved this patient's life. So the fact that they got 11 millisieverts versus having a procedure which saved their life is something we need to keep in mind. So do not sacrifice image quality for dose. And as I said, while I won't deal with the specifics of dose management in the realm of CT safety, I do provide some references here. And here is one that talks about dose management in pediatric CT, which I have provided. And stepping ahead, again, as we look at what kinds of needs there are with pediatric CT and radiation management, here are a few that I think are very important. First of all, we need to continue the emphasis on the value of imaging. This is sometimes lost in our conversations with parents, with other providers, and so on when we deal simply with dose and dose reduction. We need improved science, for example, low-dose radiation, as illustrated in this recently released National Academies report for further investigation and funding for low-dose radiation research. We need to improve other things such as diagnostic reference levels. We need to perhaps fortify our research into artificial intelligence. That is, these techniques should be applicable and tested in children before their deployment. We need to continue to fortify our partnerships, especially for education and advocacy, such as through the Quality and Safety Alliances, and always need to work on improved communication. I'll give some examples of these things specifically. And of course, we need to resource these. None of these efforts comes without the commitment of time, with money, with energy, and other resources. Here's an example of recent release of diagnostic reference levels for pediatric CT examinations in the United States. And I know a number of countries in Europe and other areas in Asia, for example, Egypt, have released similar diagnostic reference levels. But we need to continue to do these in a broader sense. And these need to be updated as technology improves, because the diagnostic reference levels should and likely will change and likely will decrease. Now, dealing with partnerships and improved communication, as you all are well aware, the Quality and Safety Alliance now has 10 total alliance organizations. There are 2 in AfroSafe English and AfroSafe French here. And these global organizations work together to be sure to leverage the resources, to not leave gaps in terms of advocacy and education for radiation, and make use of joint resources in order to promote the informed use of radiation protection in children. Effective communication, as I said, needs to be emphasized. And I've simply laid out a few simple approaches to communication, whether it's for radiation protection or any aspect of delivery of healthcare. When you're having a conversation, the 3 fundamental parts of this are to be informed, know what you're talking about, be sensitive, and to be engaged. As I mentioned before, the resources that are provided for details in this presentation include the World Health Organization Communication Radiation Risk in Pediatric Imaging. It does discuss some of these communication strategies as well as techniques for improving the use of medical radiation throughout ionizing radiation modalities. So here's an example of what not to say in a setting where a child may need a CT scan, perhaps for head injury. I heard that CT scans can cause cancer. Will my son get cancer? Possibly. What is the radiation for CT? Well, it's relatively high. I don't know exactly. How do you do CT scans in children here? I don't really know. How much medical radiation has he had? He's had other procedures. Well, I don't know. We don't keep track of that. As you can see, this does not inspire a great deal of confidence. Now, what should you say? How should you approach that? Think back to those the 3 points that I made. Be informed, be sensitive, and be engaged. How do you put that into a conversation, particularly with respect to this last example of CT? First of all, that is a good question. You're being sensitive. You're respecting the fact that this parent, this caregiver wants to know, wants to do the best they can for the child. Be informed. I can answer that. We have the expertise. We know the dosage, and we minimize radiation. This is a necessary examination. That's also important to emphasize here. I avoid numbers in terms of risks. Are there other questions? And here again, you're engaging. So you can see how this is a very effective way to promote a good communication, and you're actually taking this parent, taking this caregiver by the hand, walking them through why you're going to be a good provider for their child, and at the same time, addressing these things. You know what you're talking about, you're being sensitive to their question, and you're being engaging. And that's always been a successful formula for me. One other aspect of partnerships here, the Image Gently Alliance is recently completing a campaign with the family medicine specialty in terms of radiation protection under a broader rubric of things that are important throughout medical education, such as decision support, motivational interviewing, shared decision-making, et cetera. And these are examples of how collaboration can provide useful material, and this hopefully will not only be applicable to medical education in the United States, but may have a broader appeal here. And in the last few minutes here, I want to deal with the contrast aspect of pediatric CT safety, because it's not only radiation. So let's talk about proper utilization. Here's a good article here that dealt with a study at Texas Children's in Houston. And fundamentally, they looked at outside CT examinations of the abdomen and pelvis for acute appendicitis or suspected acute appendicitis, and compared those with their institutional protocol. Now, what they found was there's really no difference in dose delivered between the two examinations. You might say, oh, we have fulfilled this tenet of safe pediatric CT, but in fact, they really didn't address the contrast aspect of this. 15% use multi-phase examinations, and the general teaching is that less than 2% of pediatric abdominal pelvic examinations need more than one phase. In fact, there were scans that had triple phases, 8 CTs, only a delayed phase, not the portal venous or the main phase here, in 12.2%, and 10.5% had a combination of enteral contrast only or no contrast. And here is the diagram of how the individual studies were broken down. So I would encourage you to have a look at this, to think about this perspective in the optimal use of CT contrast. This is a child just the other day that came in trauma, had a head CT, a chest, abdomen, pelvis to rule out blunt chest, blunt abdominal pelvic trauma. And you might say, well, that looks fine. It's a CT examination. Of course, it's just a coronal reconstruction. No IV contrast. It doesn't make any sense to me. We're extremely limited in what we can say about injury to solid organs and vascular structures. Why non-contrast? So in fact, the dose was fine and a CT was performed, but this isn't practicing safe CT. I'm not sure why contrast wasn't given, but there are a few reasons. For one, I think there's a fear of extravasation. I'll just go through these numbers real quick. Fundamentally, in a large study of 70,000 events, there was only one severe extravasation, and it may have been that this was with ionic contrast media and not our newer agents. So extravasation is not a reason to not give IV contrast. What about adverse reactions? And I have 2 studies here, one with adults and children, showing that the overall rate was 0.03% in children of significant effects, whereas in adults it was 20 times that. So the rate, particularly in young children, of adverse reactions is extremely small. Another study just in children showed a slightly higher adverse occurrence in children, but again, type 3 events here, there were none. It was only 0.08 and 0.38% type 1 and type 2 events. So the fear of adverse reactions is not a reason not to do CT. What about acute kidney injury? And I just put a resource up here that you're welcome to read here. And fundamentally, looking at a number of covariants here that are associated with the risk of developing acute kidney injury, investigators concluded in pediatric inpatients with a GFR equal to or greater than 60 ml per minute per body surface area of 1.73, that iodinated contrast media was not independently associated with acute kidney injury. So again, this isn't a reason automatically not to use IV contrast in children. And perhaps most important and most recently, what about this issue of thyroid dysfunction, something that's gaining increasing traction and recently resulted in FDA recommendations that said that thyroid function studies should be followed in children up through 3 years of age who received iodinated contrast material. Now, there is some pushback on this amongst various specialties within pediatric imaging, including the imaging community, endocrine community. And one example of that is an article here that concluded this time there's no convincing evidence to support routine thyroid function testing in children older than 3 months. Quite a different paradigm than what was presented by the FDA. And this is currently undergoing public discussion and so on, and we'll see what the final outcome is here. So fundamentally, contrast reactions, adverse events, extravasations, acute kidney injury, and thyroid dysfunction are not in and of themselves reasons not to give IV contrast media. And so the idea to not do contrast-enhanced studies to promote safety in children is actually not correct. So in conclusion, for pediatric CT safety, be familiar with the dose reduction tactics. And I didn't go into those, but I tried to present an approach to why we think this is important and provide some resources, emphasizing that the care of children is different. We must not sacrifice diagnostic quality for a dose. A poorly done low-dose exam is actually a high-dose exam. You must be familiar with new technology in particular in terms of applying this correctly. And finally, thoughtful, informed use of iodinated IV contrast media. Overemphasizing risk in children is actually not being safe. So I want to thank you for your attention. And I also want to call out for all of those who are radiographers and technologists. In fact, those especially doing CT. Thank you so much for what you do for the care of children. You are the face of radiology, and we really value all that you have contributed to our specialty. Thank you.
Thank you so much for all speakers for your very wonderful topics that we had today in celebration of the World Patient Safety Day. And now it's time for the Q&A. I will read the question that has been submitted by the audience, and I will read it and direct to the speakers. And for the audience, if you have any questions specific to any audience, you can either type on the chat box at your it's going to be either on the right-hand side or underneath of your Facebook chat box. And then I will direct the question to the speakers. I had the first question for Sue. It's about, do prescribing radiographer have an advanced practice assignment in your practice?
Yeah, that's professional guidance, is that anybody who has a prescribing qualification or is going for prescribing qualification has to be working at the advanced practice level. Yeah.
Oh, so they have to go through all the training required by the professional board, right?
We don't have, it's not, there's no legal requirement to be an advanced practitioner. It's professional guidance that's set within the within our guidance. It's not part of the legislation. The legislation is just for a diagnostic radiographer or a therapeutic radiographer. But across all of the professions, we've all agreed that this is at the advanced practice level. So somebody should have a full master's and be working at that expert clinical level before they become a prescriber.
Yeah, I think this is a very unique role of radiographers that you are doing in your country, because a lot of practices around the world, we are quite different in terms of advanced practice. This is very, very interesting. And the next question that I have is for Amanda. This is very long question. They asked the audience asked about in the practice when you deal with the contraindication, do you prefer to have the physician around you? Is going to be either radiologists or the ER doctors? Is that happening in your practice?
I think in the UK, that mainly the radiographers work with the radiologists in the background, so not necessarily in the CT scanner. We have all of our protocols looked at by the radiologists, and we work under something called a patient group directive, so a PGD, which I presume is unique to the UK. So as radiographers, we understand when we can give contrast, and as long as we've been through all the patient questions in terms of safety, we don't necessarily have a radiologist close by. They're always on the end of the phone, but they're usually not there physically.
All right. And I think I've got the next question for Dr. Frach. And the question was, there is a move to document CT doses in patient medical charts that seems straightforward, but discussion on limiting number of procedures being performed as well. As radiologists, does seem like the appropriate approach for the patient?
There is a great deal of discussion about this, and really it comes down to should the information based on the dose of an examination or the dose of multiple examinations determine what's done next. And I do believe that the majority opinion of those caring for children and ordering examinations is that that examination is done independent of what is done before. And if it's an indicated examination, irrespective of how much dose that exam might deliver or how many exams have been done before, that examination is completed. Now, there is some debate on that, but I do subscribe more to the fact that if you follow guidelines in terms of decision support and appropriateness criteria and so on, that decision about that specific examination for that child that day should be made independent of those other pieces of information.
All right, it's quite interesting way that we are doing it back in this part of the world too, in terms of patient dose record in CT, and now it moved to interventional radiology to nuclear medicine. I think next question I would like to ask Terry, is from your presentation, is quite unique role of the nuclear medicine technologist in terms of managing the radiopharmaceutical, both dosage and safety. What do you see in terms of the training for the nuclear medicine technologists to emphasize on this role for the patient safety? Because practice may vary from one place to another. Like in some part of the world, the technologists are not the one who inject the contrast media, the radiopharmaceuticals.
Well, of course, I can only speak from my own experience in Canada, but I think that the patient safety aspect in terms of administration is really quite strongly advocated in their educational training. As I said in my presentation, a lot of what I spoke about is pretty much routine for our technologists. And I think they have a really strong impetus to ensure that radiopharmaceutical are provided for and administered in a very safe way. I'm really quite pleased with how interested the different instructors are in ensuring that our graduates are sort of at their peak in terms of ensuring patient safety when they do administer sometimes even therapeutic doses, which I recognize are not often administered by technologists in other jurisdictions.
All right, thank you. And back to Adriana and also Stuart, since you have been working on the medical equipment project with the WHO, I just would like to see both of your opinion about role of radiographers in this sense of the safety from using the equipment, because at the end we are the one who use the machine. Either of you can start. Adriana, maybe you first.
Okay. Well, as in everywhere, it is teamwork. So we all need to work together. The engineers making sure that the equipment is well installed and is working properly. Then you as radiographers using the equipment properly. And then the radiologists looking into the medical and clinical interventions. And we all need each other. So I think that's really the message. If we want to be effective with patients and we want to be really, really impactful and have good health outcomes, it comes as a team. So looking forward to keep on working with all of you. We all need each other to make an impact in the population. Thank you.
Thank you. Stuart, any comment on this since you have been working with this project for such a long time?
Well, things like contrast media injectors, they have developed over the years to become very complex pieces of equipment and to perform different functions and tools. So training is extremely important, and there must be a system in place in any institution so that there's sign off that whoever's going to use it is competent in terms of the function and the image that's going to be obtained as a result of their employment. So I think it's important that all X-ray accessories, and they're just one example, and the same applies to AMR with contrast media injectors there, and those rules and regulations about ferrous and non-ferrous items being brought into the room. So yeah, thanks.
All right, I think it's time for Donna for some say here.
Well, I want to thank all of our participants today. You can just see the vast expertise that we brought forward and great information that will be available on our ISRT website and Facebook page to watch when you have time, or take notes from these great speakers and experts from around the world. And I thank each of you for taking time to share your key expertise with our members around the world. And I look forward to more collaborations. I want to thank the ISR, Quality and Safety Alliance, and Dr. Fresh for collaborating with us on this project, and also the WHO. As always, each year you're collaborating with us. I think this is a great way for us to get information out to the people around the world that don't have access to this. So thank you everyone for taking time. I'd like to turn it over to Dr. Fresh for last words, and then we can close the program.
Well, it's hard to come behind such great hosts and panelists here, and I really appreciate the information everyone provided here. I came away much better understanding the domain of safety and imaging, so it was an honor to be part of this. I want to thank ISRT for putting this on, I have to say once again that for those of you who are radiographers and technologists, the value that you provide for the care of our patients is incredibly important, incredibly recognized by the greater imaging community, medical physicists, health physicists, and radiologists. If it is not stated, I am stating it here, and it is so welcome. So I hope that you benefited from the program here, and you can take away some information that might at least improve your practice or your understanding of what you do. So thank you again for being here. I want to thank the panelists for being on, and thank the leadership from ISRT for providing this forum for the advancement of safety and imaging for the patients we care for.
Thank you so much. And now it's time to conclude the program. And please stay tuned for our next program in October. We will announce on our Facebook and website of ISRT. And today, thank you again for all the speakers and panelists. And goodbye. Have a nice day.